Okay, I think we can get started now. I apologize if you've heard this opening statement 3 times already. Okay, but some people will be tuning in for separate sessions. So good afternoon, everyone, and welcome to this year's 2021 Matrix and GP Track Summit featuring disruptive technologies and innovations. I'm Ellen Cohn, your moderator for the session. During this poster session, we'll have 3 posters presented, and they will outline projects in telehealth that will give insight into innovations and also present new ideas to consider. Detailed data gathering and research into each of these areas is what makes undertaking telehealth research beneficial to all of us. We're very grateful to our presenters who are willing to share their findings, and I know that you'll come away with a better understanding of telehealth. Each presenter will be given up to 10 minutes to introduce themselves and explain their poster, with the remaining 4 minutes left for questions and comments. If you prefer, you may also use the chat feature on your screen to ask questions, but they'll be answered at the end of the presentation. In order to make sure all our presentations are allowed time to present, we will stay firmly on the 14-minute schedule for each. So welcome, everybody, and our first presenter is ready to go.
So thank you for having me, everybody. It's great to be here today. My name is Lacey Bloy. I'm a nurse anesthesia student from Old Dominion University in Virginia. Dr. Tina Gustin was my preceptor for this research. She's also faculty at Old Dominion University, and my mentor for the program was Dr. Victoria Good. My study focuses on remote patient monitoring and caregiver burden, specifically in pediatric, palliative, and hospice care. Dr. Gustin welcomed me into her research team at the beginning of 2020. She works with a local children's hospital that focuses on children with chronic and life-limiting disease. She was able to secure 20 of these remote patient monitoring devices for her own research in the fall of 2019. So I was interested in telehealth research, but I wanted to focus on how this remote patient monitoring device would affect the caregivers of this population. The reason I thought this was important was because children that require hospice and palliative care often experience high requirements for medical care. They have medications now that prolong their lives, which is wonderful and helps families, but with those advancements in technology and medication come increased burdens for those parents. They have to take time off work for appointments. They need special equipment to get their children to and from appointments. And they have to make sure they're planning for childcare for their other children when they're taking care of these children. So in my literature review, I found that the incidence of acute stress disorder in this population was 24 to 40%. And the incidence of PTSD was 15 to 25%. So that got me especially concerned about this population. I also found that a major barrier to alleviating caregiver burden was communication and challenges getting to and from appointments for these families. So now enter telehealth technology, specifically this RPM device. And I thought this would be the perfect thing to study for my research project. Just to be clear, the defining characteristic of remote patient monitoring compared to other forms of telehealth is that the data is sent from one place to another. So in this case, the families had Bluetooth scales that they could weigh their children on, which loaded up onto the device and then was sent to the clinic. There was also a small pulse oximeter. Caregivers had to load up pain data manually, and they also received an 18-question survey each week about the patient's signs and symptoms, if they were improving or worsening, if they needed to schedule an extra visit, or if they needed medication refill soon. These devices also had the capability to hold a telehealth visit if needed. And again, Dr. Gustin secured these devices at no cost to the families or the clinic at the hospital. So these were rolled out simply to expand the use of telehealth in this population. So my research questions were to, number one, determine if caregivers report a difference in caregiver burden scores with an RPM system in their home compared to a family that did not have an RPM system in their home. And my second research question was to determine if caregivers report a difference in perceived collaboration with their provider with an RPM in their home compared to those without an RPM in their home. So to do this, I used a convenience sample. The staff at the clinic actually chose 17 caregivers that they thought would benefit from having the RPM in the home. Now, there were 20 devices, but 3 of these families had 2 children enrolled. So that's why the RPM group came out to 17. And then they matched the control group to 17 similar caregivers in similar situations. The caregivers all received virtual training, and Dr. Gustin rolled out these RPM devices to the families in April of 2020. I collected my data between early November and early December 2020. I used a survey tool that I made by myself with help from Dr. Gustin and another content expert. The survey tool was sent out for a 6-week period with weekly reminders sent out as well. I also want to note that because of the COVID pandemic, the control group also received telehealth. They were receiving Zoom meetings for their appointments. Now, before the pandemic, that they would have just been having in-person appointments, but I thought, even though they're both receiving telehealth, I could still compare the remote patient monitoring versus normal telehealth, and hopefully find something interesting. Because as I mentioned, with the Bluetooth capabilities and sending the vital signs, that does seem to be an advantage with the RPM. The independent variable was obviously the participation in the remote patient monitoring system. And then the dependent variables were the self-reported scores from the caregivers. As well, the survey included Likert scale questions. It also included a few free response questions regarding how the pandemic had affected them. And it also included some demographic data that I'll get into here. So looking at the demographic data, you can see it's the blue chart here in the middle. You can see the average age of the caregivers were 42. They were almost all female. There was only one person that identified as male in the group. 92.3% of them were biological parents. There was only one adopted parent. You can see that although I had 17, the most people I could have in the study were 17 in each group, I received 7 responses in the RPM group and 6 responses in the control group. The average length of time that a family or a caregiver or their child was enrolled in the pain and palliative care program was 19.5 months, which I thought was interesting. Nobody was really a stranger to this program. They'd been all there for about 1.5 years. So I thought that was interesting, considering now they're adding in this RPM technology, which they had never had before. And the other thing I thought was notable was that the average number of children in the home was 2.54. So these families have between 2 and 3 children total in the home. So they're busy people. They've got a lot going on. Moving into the collaboration with the provider, my findings there. These were not all the questions that I asked on the survey, but these were 2 components that I thought had interesting results. Now, unfortunately, when I analyzed my data, because of the small sample size, I didn't find any significant p-values, but I think these numbers still show some interesting findings. So under collaboration with the patient's provider, you can see that in the RPM group, all of them reported either a little more or a lot more collaboration compared to the control group. 4 of the 6 said that their collaboration was the same throughout that through the 6-month period. In the survey, I asked how the families felt about these factors in the last 6 months. Also now, ease of communication with provider. You can see that in the RPM group, 100% of them reported either a little more or a lot more ease of communication, while 50% of the control group still reported the same amount of collaboration with the provider. And then finally, the caregiver burden assessment. There were also several questions that went along with this, but I chose to include nervousness or depression because you can see, although throughout the pandemic, almost everybody reported a little more or the same amount of nervousness or depression. The RPM group did show two respondents reported that they had a lot less nervousness or depression over this last 6 months. So I thought that was interesting too. The other thing I did want to include about some of the free responses I asked was that a couple families reported that they had a seamless rollout with the telehealth or with the RPM device, which I was pleasantly surprised by. Certainly you expect when something like this is rolled out, you'll have some kinks to iron out. So even though I didn't find any significant p-values with my data analysis, I still think my study is important for the expansion of telehealth in this population. Limitations, of course, small sample size, and I did get a few reports that this device is clunky. It's not entirely tailored to children. So another opportunity for improvement in the future. And that's my time, I believe. So what questions do you have?
Thank you. Perfect. How about questions from the group? The questions have been wonderful, so I encourage you.
Is anything coming in on the chats? I can't see.
I just unmuted myself. This is Jasmine. I just want to say this is a great study. I know you were kind of disappointed in the significant p-values, but this data, personally, a coworker of mine experienced exactly what you indicated here with the post-traumatic stress disorder. Her daughter was passing of cancer, and she was having to go to the nearby VCU medical center, or the VCU health system, but that medical center for care. And she got to a point where she was very over it. And it just overall, I mean, it's hard on them anyways, but just having this convenience, she said she was constantly at the hospital. And I just remember incidents of her saying somebody parked wrong near her, and she just went off and wrote on the car with red lipstick. So you said what?
I said, well, lipstick, that comes off. That's good.
Yeah, it comes off. So that's why she done it. And she was so burnt out with going to the hospital. So I think I hope more facilities pick this up. I think this is great.
Mm-hmm. Something I didn't get to mention in my presentation was that in my literature review, I learned that before 2010, only 12 states had laws ensuring that insurance companies would reimburse for telehealth care. And now here we are, jump forward to 2020 and beyond, a lot more health insurance companies are reimbursing for this form of telehealth. So I do think it will move on. It will expand.
I agree. I think also COVID-19 has catapulted that a little bit. Mm-hmm. They need to reimburse it because some people won't get care. So
right. Anything else from anybody?
Any more questions? Looks like you had an interdisciplinary team. Could you talk about that?
Yes. So that was right. Something I didn't necessarily expect to jump into, but was pleasantly surprised. The clinic at the local children's hospital has one physician. Now they have two physicians. They acquired another physician over the summer. So they've got two physicians and a nurse, and Dr. Gustin acts as the clinical nurse specialist. So she used her own research project to kind of bring in the telehealth technology. But before the pandemic, the main physician, she would drive to patients' houses if they really needed a visit on her own. So she was putting in a lot of man hours to do this. So the telehealth technology not only helped the patients, but it helped the physicians see more patients as well. And they were, of course, wonderful to work with. They were very excited to get this device out there and learn how the families felt about the device. So actually, I'm setting up an appointment with Dr. Gustin very soon to formally present my research to the Pain and Palliative Care program physicians and providers and the administrators that help make this happen to share my findings and how these families feel about the devices.
How about the transmission of data? Were you pretty were you feeling good about it being HIPAA compliant? Was that a concern at all?
That side of things was entirely with the physician and the nurse at the clinic. I sent out my survey regarding their perceptions and their perceived collaboration via a red cap survey, which was as anonymous as I think you can get it. I did have to get the caregivers' email addresses, but I've since trashed those. I don't have those anymore. So everything else was anonymous from that standpoint. And nobody mentioned anything in my free responses about fear of security breaches or things like that, sending in their information. From what I understand, the information that they upload to the devices is sent within the intranet at that hospital. I forget, I think it's like called Connect Care or something at that specific hospital. So it's these devices, they only connect to the children's hospital. They don't have any other capabilities from what I understand.
Great. Sounds important.
Mm-hmm.
More questions?
We might be close on time.
We're actually 1 minute to go. So we covered another excellent poster. Really appreciate it. And we will now give you a rest and go on to, let's see, an overview of the telehealth implementation. I don't have the rest of the
support tool.
Are you okay putting your poster up?
Yep, I think there we go. Now I can share my screen.
I'm not seeing it yet, but
Yep, do you all see it?
there we go.
All right.
Thank you. Great.
Great. So let me just change this view if I can. Well, it's not really changing, but that's okay. So pretend you can see the top. Somehow it's not working, but it's it's an overview of a telehealth implementation support tool for jails that we developed. I'll just talk through the process that we use to develop it. I'm Syra Hawk. I work for RTI International, which is a nonprofit research institute, and I direct the data interoperability and clinical standards programs there. Now, for this project, I worked with our criminal justice researchers, and I was not that familiar with criminal justice research in general, or really in practice. So I learned a lot about this whole new area for me, but really an area that's important when you're thinking about telehealth. And so the idea is to talk about just in terms of the objectives. I'll just scroll down. Considerations in selecting telehealth services. We also identified some core concepts to consider when implementing telehealth in jails. And then we're in the middle of the evaluation part right now, so we'll just talk a little bit about evaluation. So in terms of background, we are a technical assistance provider for the Bureau of Justice Administration's project that deals with opioid use disorder and behavioral health across different types of grantees. And the name is their Comprehensive Opioid Stimulant and Substance Use Program. Now, the grantees are not, oftentimes in health services research, our grantees are maybe community organizations or hospitals. Here, the grantees are local jurisdictions. And so that can include drug courts, sheriffs, jail administrators. It's really a whole different type of grantee than perhaps what we're used to. And the reason I bring that up is because oftentimes in health services research, or in health, when we're putting together a pilot, we're doing it in a healthcare organization. Jails and prisons actually provide a lot of healthcare, but that's not really their primary focus. They don't exist to provide healthcare. They provide healthcare as part of their existence. And for me personally, that was a little bit of a shift because I know in the beginning, I was talking to someone at the Bureau of Justice Administration about patient preference, and they kind of were like, yeah, but that's not something we do here. It's a little bit different because they don't have patient preference in the same way that we're thinking about it because people are incarcerated. So anyway, as the pandemic continued, there was an increased interest in telehealth by the grantees. Part of it was due to COVID-19, but part of it was not. Some of it is because it's traditionally very challenging to provide health care in jails. It's hard to get enough providers. Oftentimes jails and prisons are located in places that perhaps are not desirable, or it takes a long time to get to. There's security requirements that are really not so fun for providers, and providers are often really busy. So it can be difficult to get the care that people need. At the same time, the jail and the justice involved population is disproportionately impacted by the opioid epidemic. People who are involved in the criminal justice system are 100 times more likely to die of overdose than the regular population or the rest of the population. So in terms of the general population versus the justice involved population, there really is a lot of need, but at the same time, it's difficult to provide care. So that's one reason why it's really important to think about this population. Also, it's a unique environment in a correctional facility. It's different than a hospital or a school or a clinic. The security provisions are different. You have to think about transfers even within the facility in a more secure way. So there's a lot of reasons why it's important to think about telehealth for jails a little bit differently. And I have to say, honestly, I was not very familiar with this, but I've learned so much about this population, and now I've kind of taken this up as my mantle because really, when thinking about the need and the ability to make a difference, this is a big place to do it. So a lot of other folks also had this idea, but these grantees, they're criminal justice people. They don't really know how to start or implement a telehealth program. And honestly, a lot of providers didn't either when the pandemic came. So, this was really a timely exercise for us. So this is what we did. We really wanted to provide some service for them so that they could learn about factors that relate to telehealth readiness, select services because, not every service is appropriate for telehealth, and really for jails in general, they might not really want to start with everything all at once. They might want to start with one, prioritize what they should do for implementation, and then get some guidance for things that they need to do. So the idea was to really provide a support for jail administrators and clinical staff to use. So what did we do? We developed a tool called the TIST, the Telehealth Implementation Support Tool. We're not creative. I tried to come up with something that related to like handcuffs or something, but I guess we're not allowed to do that, and we're not allowed to say inmate. And so there's all these things that I've learned. So, so the TIST it is. But regardless of the name, it actually is a cool tool. Regardless of that, this is a web-based tool that really takes people through it's a self-administered tool that takes people through questions that will help identify their readiness. And how did we come up with the questions? Well, the first thing we did was an environmental scan. So we reviewed the literature, both peer-reviewed and gray, about telehealth and also criminal justice. So we looked at a number of different keywords. We had a librarian help us with both the keywords and the searches. And so we're really trying to hone in on what our best practices for telehealth across the spectrum of criminal justice. The TIST is really focused on jails, but we also looked at prisons and drug courts, things like that. And for people who maybe are not as familiar, jails are really designed to be less than a year, and prisons are long-term. So when thinking about healthcare needs, you also have to think a little bit about ongoing management versus initial conditions. And so you can see the databases that we searched. We also did some stakeholder interviews to identify concepts. That's right over here. So we tried to get more, but we talked to 5 people who either were clinical staff or administrators of jails throughout the country who had some expertise and experience with jails and with telehealth. And so with those, we used to develop our core concepts and also the questions. And then we made tip sheets. So what that means is that we would take people through, say, service selection, some questions about that. But then after the questions, what do you do? So then we had these tip sheets that we designed using the literature that were easy to use, easy to read, and really just designed for folks to use to get more information. And those are available either on the web, or they could download them as a PDF or print or whatever. And I recognize that if it's telehealth, why would we want to print? But that's sometimes people, you have to meet people where they are. And so then we developed the tool in paper, and then we web enabled it. We have survey methodologists at RTI. We actually do the US News and World Report Best Hospital Survey, and NISDA does a survey. So we do a number of different surveys. So we got those folks involved to help design and develop the tool. So that way we're not asking questions in a way that might lead people to a certain answer, and then also the scoring. And then we developed guidance to accompany the tool with resources. And then we're currently user testing it. So, and then the idea is that once we test it, we'll make some changes and then take it to the broader community. And so now I'm going to stop sharing, and let me see if I can get the tool up and running so that you can see it, because that's probably more fun here than actually listening to me talk about it.
This is great. We got 2 minutes to go.
Okay, that's fine. So it's, of course, my computer is being slow. And so it's, oh, here we go. Let me share it real quick. Share. So I just thought it'd be easier, rather than putting it on a poster, you can see what it looks like. So these are the concepts. People will click on a concept. Let's pick core readiness, and then answer questions. They can go back to the concept menu. They can go to their results. And then this is the guidance that I was talking about. So they can look at guidance, which is a tip sheet or two basically for each thing. They can go other places for telehealth resources. So these are other items. And then the paper tool, if maybe which is PDF. And I think that might cover the time. So I will stop sharing and see if anyone has any questions.
Just wonderful. Very interesting. How about questions from the group? I know this group has been enlarging, and you've been great with questions coming up. I'll ask a quick one. This looks like an ensemble book possibility, this field of telehealth. And have you seen a book like that yet?
You know, I've heard that one might be coming, so we'll have to see. I would be interested. I think there's so many uses that are coming about, and I think people are looking at telehealth in all different ways and the whole spectrum of virtual care. So I think that would be terrific. Haven't really seen anything yet, but that doesn't mean it doesn't exist.
If you need help writing a proposal, not as part of the book, but
Sure,
feel free to contact me.
I will. Thank you.
Questions from the group? Randy's shaking his head no, but you look like you might have one.
Well, I was a latecomer to the party, so I feel like I came in the middle of the movie. I don't think I have a really good question. I do think just listening to a little bit of your conversation, the whole idea of delivering healthcare to jails and prisons is interesting. I work at Duke, and I see prisoners coming in all the time to the eye center and the process of getting them there. Now, granted, that's a specialist, and I don't know if you dealt with specialists versus general care, and you got any thoughts maybe of that, but I certainly see where there is having to come to expertise, in the process around that. It's an interesting one to watch.
Yeah, I agree. The most common specialist that we were involved with was for behavioral health, which kind of makes sense given the population. But I totally agree that even within the primary care and specialist spectrum, there probably are some services, depending on what kind of devices are available too, that can be provided virtually and what can't.
Diagnostic equipment and all that. Yeah.
Yeah, exactly. So I think this will be, but really, one transfer is very expensive, and it involves risk to the staff, and also risk of contraband coming back in and all that sort of thing. So even it might be worth it for a correctional facility to buy equipment rather than have transfers just because it's so costly
Mhm.
and dangerous.
Yeah, and that was interesting. I mean, just observer watching coming and going transfer prisoners, and usually at least 2 guards, a whole vehicle, and the whole 9 yards. Very kind of wow, it's a big process.
That's right. And then they have to backfill those folks at the
Mhm.
correctional facility because you can't just, everyone else
Right.
can't just sort of pick up the
Yeah,
slack.
that's right. No, interesting. Thanks. Sorry, I just caught a
No,
bit
thank
of it,
you.
but I appreciate it.
I have a question about the economics. I've always heard this is the low hanging fruit. It just seems a little crass to me to speak about it like that, but that's what I've been hearing for many years. Is this economically viable, or
Well, like many things, it depends. But in terms of reducing transfers and reducing overall costs, I think that those are probably the two biggest benefits that are easier to quantify. Transfers, you can easily quantify how many you had, from year 1 to year 2. And then also for more, this is more for prisons than for jails, but people involved in the criminal justice system have disproportionately high rates of chronic disease. And so by better managing that disease, perhaps there could be a reduction in costs generally and better outcomes.
so
Some of that is out of their control because of diet and things like that, but
have you seen published economic analyses of this yet?
there are some, but it's pilots,
Uh-huh.
as you might suspect. So I think it'll be interesting to see what happens post-pandemic. I know in Michigan, Wayne State is working a lot on this, and so I expect that they'll probably put something out. And this whole grantee program, which is funded by the Bureau of Justice Administration, it's really made up of criminal justice types versus researchers, but we are involved. So I expect that we might be working on that a little bit as well.
Sounds really exciting. Well, we're going to move on to our third poster. And Jasmine, looks like you're geared up here.
Yeah, I was actually going to comment on the jails Sierra's post. Her presentation as well. Working at VCU Medical Center, we had a contract here in Virginia. We had a contract with the federal prison system to care for inmates. And just with talking and watching the logistics of it and all the guards and et cetera, I did learn that not many facilities have contracts with the prison system. So again, for as an economic perspective, that's a benefit to not have to worry about contracts and who will care for these prisoners. So just adding that to it.
That's a really good point. And then also, even if there isn't a contract, that means every time someone is billed at kind of the highest cash rate,
you know
which,
it.
you know how that works. I don't have to tell everybody. So that's another factor to consider. Thank you for bringing that up. I'm going to put that in my points.
Great. Well, we're so excited for our third poster. Are you okay about sharing it?
Yes, I'm okay with sharing it. I'm going to close my computer, behaves. All right, so I'm also going to minimize these videos. Okay, so hello, my name is Jasmine Landrum, and I am a nurse executive DNP candidate at Old Dominion University. I'm also a registered nurse at Hunter Holmes McGuire VA Medical Center here in Richmond, Virginia. So my poster is titled Use of Telehealth in a Veterans Affairs Transplant Center. As you'll see on my poster, my academic advisor or faculty advisor is Dr. Nancy Noble. This topic was actually inspired through my mentor, who's down further on my poster title, but it's Dr. Ho-Chung Gillis. She initially did focused her capstone project during her DNP studies on waitlist approval and the effects of how telehealth impacted that. So just determining and figuring out what exactly the facility or the Department of Hepatology, what they needed, we determined that it would be good for me to transition that study into, or further that study into the efficacy of telehealth. So just a minimal background, telehealth does, when it takes place within the veteran population, well, since COVID-19, it's actually changed some, but prior to COVID-19, when it takes place within the veteran realm, it takes place at referral centers or basically at that veteran's local VA, which the local VAs may not have access to all of the services, for example, transplant or various organ transplant centers. So my study will focus more so on the inner workings of telehealth. So some background on veterans. A vast number of veterans live in medically underserved locations. In fact, it is estimated that 50% of veterans are referred for liver transplant that do not have immediate access to a Veterans Affairs Transplant Center or VATC. It is determined that increased distance to a Veterans Affairs Transplant Center negatively impacts or negatively affects the likelihood of being placed on a transplant waitlist, meaning receiving that organ. So the purpose of this study is to evaluate the efficacy of telehealth, of a telehealth visit compared to an in-person visit. This study will evaluate veterans referred to a VATC for liver transplant specifically. And this study will provide an in-depth investigation of current telehealth usage in order to expand the existing program, as currently they're looking at doing live donor transplants. So the data from this study will definitely support utilizing telehealth in that realm as well. So the methods involved were a retrospective comparison of transplant candidates who underwent the initial evaluation of liver transplantation by telehealth, with those evaluated by in-person or on-site visits at the transplant center. The in-person evaluation involved transporting the patient and caregiver to and from the VA transplant center, as well as a face-to-face office visit with the transplant team. Telehealth visits were performed through secured video conferencing. And as I mentioned before, that's typically at their referral centers. But of course, during COVID-19, some different modalities have been explored. So I anticipate the veteran population also utilizing VA Connect Care for their telehealth visits. So the inclusion criteria for this study, veterans referred for liver transplant between 2014 and 2019. The exclusion criteria were the emergency referrals, ineligible veterans deemed ineligible based on clinical or psychosocial criteria. And that part was a significant finding for myself in doing chart audits and chart reviews, because I didn't really anticipate the social need for veterans receiving a transplant, such as a liver. So socially, if they didn't have a person willing to commit to being their support person, bringing them to appointments, which of course, if these patients were traveling miles and miles, that's a huge commitment. So that would result in denial for waitlist placement on the organ waitlist. Tracer was also used. It's a secure database, web-based transplant referral website. It's managed by the National Surgery Office, and essentially that's where veterans are listed for their organ. That database was queried for demographic, clinical, and outcomes data. So Google Maps was also used in the incognito mode to, of course, to be HIPAA compliant. It was used to calculate mileage from residents to the VA transplant center. And the National Quality Forms Telehealth Measurement Framework was utilized with their elements and domains of access to care, financial impact and cost and experience, as well as effectiveness. Although for this study, I couldn't do the experience due to the parameters on sending out surveys. It goes through a whole list of approval. And with the Veterans Affairs system, it's big to just have your project approved through the board. So getting a survey approved is just an added layer. So my mentor, as well as my advisors, steered me away from that. Although I do think that is needed. So I did also use SPSS version 27 for statistical analysis through independent t-tests. So I had a total of 3 research questions. Research question 1 is there a significant difference in the completion time between the is there a significant difference in completion time of comprehensive pre-transplant evaluation of veterans referred for liver transplantation between the use of telehealth compared to in-person evaluation at a VATC? Question 2, is there a significant difference in the amount of travel for pre-transplant evaluation for veterans referred for liver transplantation with the use of telehealth compared to in-person? And is there a significant difference in the amount of tests veterans undergo when referred for liver transplantation with the use of telehealth compared to in-person evaluation at a VATC? So the study cohort consisted of 136 veterans. Initially, I audited 142 charts, but of them, the ones that met the inclusion criteria were 136. 111 of those veterans were utilizing telehealth, and only 25 were actually in person. So as for demographics, the majority of veteran liver transplant candidates were white males in the age range of 61 to 70. Hepatitis C and hepatocellular carcinoma was the leading cause of liver disease at 22.8% of veterans referred. A large portion of the veterans were referred from San Juan, Puerto Rico, and Columbia, South Carolina, both consuming 11% of the sample population. Additionally, of course, veterans from these areas, they will require telehealth due to travel.
We are unfortunately at the end of your 10 minutes, but this was so fascinating.
Oh, I only had 8 up here.
You have 8 minutes?
Yeah, I only have 8 because I have mine timed.
I'm sorry. Well, I'm going to trust your timing. Keep going.
So the results of this study, I discovered a statistical significance with the 2 research questions involving the amount of travel and the number of tests performed during the evaluation timeframe. In terms of completion time of pre-transplant evaluation wait lists, or pre-transplant evaluation and waitlist evaluation, there was a significant difference, was not a significant difference, I'm sorry, on those. Although there wasn't a significant difference, it is still affirmative to know that telehealth does not negatively impact the timeliness and it matches in-person standard of care. So in regard to research question 2, regarding the amount of travel, there was a significant difference in that. The data revealed that there is a significant difference in the amount of travel for veterans receiving telehealth in comparison to those receiving in-person care. Veterans receiving telehealth naturally live further away. So this finding supports the need for telehealth. As we know, telehealth provides services to individuals experiencing large gaps in care due to geographic access to medical centers. So lastly, there was a 35% reduction in the number of tests performed at a VA transplant center when using telehealth. So veterans receiving in-person care had a significantly higher number of tests performed at a VA transplant center. So veterans utilizing telehealth often had the majority of their tests performed at their local VA. So this finding reveals the potential cost savings of for VA transplant centers when having telehealth patients. So I'll quickly, since I now am at 10 minutes, so the findings from this study can contribute to the development of best practices for future applications in remote waitlist monitoring or post-transplant management. Program performance of completing liver transplant evaluations based on the study results can be incorporated into continuous quality improvement initiatives to improve the efficiency of navigating referrals to a listing decision on the organ transplant list.
Lovely, and very important. And I remember walking past Dr. Starzl for years at the University of Pittsburgh with his dogs. Lovely man. He was the father of liver transplants. So
awesome.
I have a warm heart for this particular poster. Very, very nicely done. Any questions from the group? We've had some wonderful interaction.
I have a question.
Mm-hmm.
My name is Ed. I'm a retired Navy commander, as well as a former VA employee. I'm a candidate currently. And I want to say thank you for working at the VA first.
Thank you.
And I
Thank
want to
you
let
for
you
your
know that for the feedback from all the people I work with and all my friends, doing the telehealth is the way to go. As you noticed on there, if you're within maybe 40 or so miles or 50 miles of the transplant facility, it makes sense to go there and drive there because you get the in-person experience. But when you're hundreds of miles away, it's a real burden and a lot of stress on the individuals. And I like to see that you did provide the data. So thank you on that.
Thank you. Thank you. Yes, the VA, the services offered through telehealth have expanded even more since I began this study. So, I mean, people can do it with their phone now, and it's awesome.
VA training and systems are some of the best in the world. They've been ahead of the rest of us in many cases.
I know, surprise. It's interesting coming from another medical institution. It's interesting.
Any more comments? Thank you for that one.
No problem.
How about some more? Even the instructor stare is not eliciting more questions. Is there something we should have asked you that we didn't, that you want to talk about?
No, not really. Let's see, because I minimized that. But no, honestly, I think we talked about pretty much everything. I don't have too much more to add. Of course.
I have a question, follow-on question. I see in your data you have 3 times the amount of tests for in-person versus telehealth, but you also indicated in your lecture that it was enough, the tests were enough and adequate for the telehealth. Is there any reason why that there were 3 times the amount for in-person?
Yeah. Right. So the hard part, some of the limitations, of course, of this study was when the patients were in person. Of course, this was that typically meant this was their local VA. Occasionally, Hampton, Virginia was the local, so it's about 60 miles plus from Richmond, Virginia. But what would happen then was it's determining which tests to include from inpatient stays, because some of these patients would be pretty sick and they would end up coming in for ascites from liver disease and things of that nature. So then they're getting constant labs. So for the telehealth patients, when that would be happening, it's what can I say? It's absorbed on their local VA. So more so, these would be patients coming to us and having to receive their care here at the Richmond VA.
So thank you, and
Thank you.
wonderful, wonderful questions in poster, and it's my job to land this plane on time. So I have the same short closing statement you probably heard 3 times, and for that I apologize. Okay, so I want to thank all of our presenters. Really, these were excellent posters in our audience, and encourage you to vote. Definitely vote for your favorite posters. But I want to say that because you were accepted, your poster was accepted, your poster went through some pretty rigorous blind peer review with a huge rubric. So you're already all winners in this. If you have any further questions or you want to continue the discussion, feel free to contact the presenters. You can look up the attendees, you can message them to connect at networking tables, or you can email them. So it was a privilege to moderate your posters. Your really fine work, and I hope it continues, and I hope to see you next year at Matrix. Okay, so we're going to close down now. And thank you all so much. It was really an honor to be with you all.